Clean up your act. Good morning once again. We are here to video the visual inspection and bony palpation of the elbow. Once again, we are sanitizing like you would coming into the class. There would be a bottle right in front of you. And when you go between patients, you do the same thing. And when you leave the room, you would sanitize. So make that a habit. Also, you know Nate. Nate, we are going to be examining, as per your request, the muscles and bones and tissues and the motion and the function of your elbow. May I have permission to touch your upper extremity so that we can test all of those things?
Yeah.
Okay, you have all the power here. Let me know if something hurts, because that's what we're trying to figure out, or isn't in the right relationship or injured, and keep me informed. Okay, don't mask anything, please. Very well. The elbow is a, would you please go check and make sure the video is running while I talk to him? I want to make sure I hit the right button. Are we recording? Good, we got a thumbs up. The elbow has three joints. We have the humeroulnar medially, we have the humeroradial laterally, and we have the radioulnar laterally. Most of this is a hinge joint, the humeroulnar. If you do full extension, we'll have a bony block. Okay, that's normal. And then we're limited by soft tissue with flexion around a medial lateral axis in the sagittal plane. We do, however, also have supination and pronation in the transverse plane in anatomic position around a superior inferior axis. That is because of the pivot joint on the humeroradial joint, and it doesn't matter to me or clinically. You'll hear humeroradial or radiohumeral. Just make sure you say right or left with that. It goes along for the ride with flexion and extension, but with the pronation and supination, that is because of the pivot joint right there. Visual inspection, when the client walks in and relaxes, it is normal for the palms to face inward. In other words, the hands pronated halfway, and excuse me, the elbows to be cocked a little bit this way. However, when standing in anatomic position, our assessment position, we're here. And what is normal with the visual inspection, of course, we're looking for fluidity, symmetry, posture, proportion, color, contour, condition, creases, etc. With the visual, what we normally see is 5 to 10 degrees of valgus at the elbow. The distal end of the distal segment of the cubitus or elbow is away from the midline. So bilaterally, we have this. The elbows are tucked into the waistline and the wrists are further away. This becomes more pronounced if the person is holding a bucket of water. But anyway, normal is 5 to 10 degrees for a male and 10 to 15 degrees for a female. Why is that? Because truly at puberty, when the female's pelvis broadens, they would be swatting their backside if they didn't have more valgus. So they have evolved, whatever you want to call it, to having more so that they don't swat their backside, because they have the hourglass where the men are more V'd and don't need to have the valgus. So valgus is normal up to 10 degrees for a male, up to 15 degrees for a female. If it's more than normal, we would say an extra valgus or a lot of valgus. Wow, I'm really messing up today. Anyway, and the cause of that is usually because of a fracture, intracapsular fracture of the condyle, which involves the epiphyseal plate. So things are messed up here and the growth plate is altered and it causes a greater valgus, is typically why. You may see another condition with visual inspection called gunstock deformity, which is, if you look in Hoppenfield at the figures early in the chapter, I have to flex my elbow and internally rotate to give the look, but it looks like the stock of a rifle and then the barrel of the rifle, and that's their normal standing position. So it's reversed valgus, it's a cubitus varus. And that's typically secondary to supracondylar fracture instead of condylar fracture. The valgus will involve the epiphyseal plate, and the gunstock deformity is supracondylar or proximal to the condyles. We'll put the arm into a gunstock deformity. Another thing you may see, Hoppenfield doesn't mention, but he did in the shoulder, is Erb's palsy. If there's a problem or a pathology, some sort of paralysis going on at the elbow, then the elbow may go into a flexion contracture. And it'll be a slight flexion of the shoulder, a definite flexion of the elbow, and a flexion of the wrist and the fingers. And that's due to neurologic trauma. That can be in the CNS and motor cortex, opposite side, or it can be a peripheral nerve that will do that. So this is our visual inspection. People vary how they swing their arms when they walk. People who are larger will swing more out like this, and they may or may not swing their elbows. It might just come from the shoulder. Some people will flex the elbow on one arm and keep a straight arm on the other. So if it's not painful, then it's likely not pathologic, even though it may be different. Okay? This is our visual inspection of the elbow. Now let's go to the bony palpation. I'm always working at center of gravity level with the client rather than standing up above them, etc. So here I'm kneeling down while he's there. I've got permission to touch his arm. We're going to put the arm into a slight hyperflexion, which exposes the elbow that we need to see. Holding the arm in this position, we're going medial around posterior to lateral. And there's not many bony landmarks here. Medially, initially, you're reaching with the arm extended. You are reaching, wrapping your hand around, and you can feel the medial condyle of the humerus. Okay? The medial condyle of the humerus. And you're just going to palpate around it. Then we move from there. Now we can see it better this way. I will approach it from here, but you would be here. And you're going to palpate around relax your arm, please. There you go. And I'll hold it slightly at 90. The olecranon process of the ulna. And I'm palpating around it. If you may get a localized swelling here. If you do, it's likely bursa, and it's considered localized. If the bursa is inflamed or swollen, which feels like a boggy sac, then it's likely secondary to direct blunt force trauma or an overuse of extension, but usually a contusion mechanism. If the swelling is diffuse, it's all around, then that usually means fracture, and it's probably a supracondylar fracture or a crushing mechanism when you have diffuse edema in the elbow. Feeling the olecranon process, this is actually the proximal aspect of the ulna, and the ulna is subcutaneous all the way from proximal end to distal end. So I can palpate all the way down the length of that, just like the shin bone of your tibia. It is subcutaneous, and I can palpate all the way down the length of that ulna to the styloid process. And then we'll palpate back, and I'm just kind of milking it, clear to the olecranon process. At the olecranon process, there's a unique relationship. I'm going to bring it here. and go this way. When the elbow is flexed, we have the lateral epicondyle of the humerus, the medial epicondyle of the humerus, with my middle and thumb fingers, and then the index finger is on the olecranon process. If the bony relationships are correct, and that's why we're assessing, is proper anatomy, proper relationship of tissues, and or any pathology, you should have an isosceles triangle right here with the elbow flexed. When the elbow is extended, the olecranon process then lines up with the other two, and you have a straight line. That is normal. Isosceles triangle, straight line. Back to the olecranon process, when you slightly flex the elbow and it's relaxed, we have bursa, we have triceps tendon and aponeurosis covering this area. But if you palpate deep enough and the arm is relaxed, you can get down into the sulcus here and actually the olecranon fossa. There it disappears because the olecranon process is in the way. And here I can palpate down in there once again. But at this point, we're not doing the soft tissues. From the olecranon process, we're going to go lateral. I might have just named this the lateral because the arm's cockeyed to me. Medial epicondyle, lateral epicondyle, olecranon process. Again, isosceles and straight line. Moving now to the lateral epicondyle of the humerus. It's not as large as the medial epicondyle, not as prominent, but it's still subcutaneous and quite prominent. Palpating it, we're going to travel around its borders and listen to it. And from here we have a supracondylar ridge. It's kind of a razor's edge ridge that travels up, proximally up the humerus. The lateral supracondylar ridge actually travels clear up as far as the deltoid tubercle with some people. But you can roll your step off the olecranon process, lateral epicondyle, not the olecranon process, the lateral epicondyle, and then you cross fiber here, you can feel the little ridge. This ridge serves for soft tissue attachment, which we'll talk about in another video. But you can feel that supracondylar ridge. There is also a supracondylar ridge coming off the medial epicondyle. Not as prominent, and it's deeper, but it is there. If you have problems on the supracondylar ridge, it may affect the median nerve, which will affect down in the thumb area of the hand. Medial supracondylar ridge, more prominent, lateral supracondylar ridge. Back to the lateral epicondyle, where in this position, watching their countenance, you step off just distal and you roll right off of it. A little teeny divot, but right now, the superior aspect of my palpating finger is on the lateral epicondyle. I'm in the divot, and at the same time, the lower or inferior aspect of my palpating finger is on another bony knob. That is the head of the radius. Not much distance in there. In fact, I can feel them both just by doing this. I use this finger because it's very sensitive. It doesn't get used much, and it's longer than the others, so the others don't get in the way. From the head of the radius, you can step off slightly and it disappears again. That's the neck of the radius. That is where the annular ligament runs. I'm going to have you, please, I will passively have him supinate and pronate. And when I step off the head of the radius, the lateral epicondyle to the head of the radius, I can feel that head of the radius pivoting underneath my finger right here. And by doing this, I'm touching about 75% of the surface area of the head of the radius. And do you need to report anything to me there? Any discomfort? I didn't pick any up here. Excuse me for fumbling so much this morning. I don't have my gum and I don't have my whistle wetter, and so the meds have really given me a lot of cotton mouth in a short time, so I'm stumbling all over my words. I'll take care of that for the next video. This is the visual inspection and bony palpation of the elbow. Thank you.